Question 1. Bone physiology and metabolism. Which of the following best explains the role of parathyroid hormone pH in bone metabolism? A. pH stimulates osteoblasts to deposit new bone matrix, increasing bone mass. B. pH inhibits osteoclast activity, reducing bone resorption and strengthening bone. C. pH increases calcium resorption from bones by stimulating osteoclast activity, raising serum calcium levels. E. pH primarily acts on the intestines, reducing calcium absorption and promoting bone formation. Answer. pH increases calcium resorption from bones by stimulating osteoclast activity, raising serum calcium levels. Explanation. Parathyroid hormone pH plays a critical role in calcium homeostasis and bone metabolism. When serum calcium levels drop, pH is secreted by the parathyroid glands. Its primary function is to increase calcium levels by stimulating osteoclast activity, leading to bone resorption and the release of calcium into the bloodstream, increasing renal reabsorption of calcium, reducing urinary calcium excretion, enhancing intestinal calcium absorption via activation of vitamin D calcitriol. Incorrect answer. Analysis. A is incorrect because pH primarily stimulates osteoclasts rather than osteoblasts. Osteoblasts do play a role in bone formation, but pH does not directly stimulate new bone deposition. B is incorrect because pH actually promotes osteoclast activity, not inhibition. D is incorrect because pH increases intestinal calcium absorption rather than reducing it. Relevant guidelines. The National Osteoporosis Foundation (NOF) and International Society for Clinical Densitometry recognize the importance of pH in metabolic bone diseases such as osteoporosis and hyperparathyroidism. Question 2. DSA scan interpretation and clinical application. A 63-year-old postmenopausal woman undergoes a DA scan. Her T-score at the lumbar spine is negative 2.8, and her T-score at the femoral neck is negative 2.3. Based on the World Health Organization (WHO) criteria, how should her bone mineral density (BMD) be classified? A. Normal. B. Osteopenia. C. Osteoporosis. D. Severe osteoporosis. Answer. C. Osteoporosis. Explanation. Bone mineral density (BMD) classification follows the World Health Organization (WHO) criteria. Normal. T-score equals negative 1.0. Osteopenia. T-score between negative 1.0 and negative 2.4. Osteoporosis. T-score equals negative 2.5. Severe established osteoporosis. T-score equals negative 2.5 with history of fractures. Since the patient's lumbar spine T-score is negative 2.8 equals negative 2.5, she meets the WHO criteria for osteoporosis. Incorrect answer. Analysis. A is incorrect because T-score of negative 2.8 is far below the normal range. B. Incorrect because osteopenia includes T-scores between negative 1.0 and negative 2.4, but the lumbar spine T-score of negative 2.8 qualifies as osteoporosis. D is incorrect because severe osteoporosis requires both T-score equals negative 2.5 and history of fractures, which is not mentioned in this case. Relevant guidelines. The IST official positions and National Osteoporosis Foundation (NOF) guidelines emphasize that T-score equals negative 2.5 is the threshold for diagnosing osteoporosis and recommend treatment to reduce fracture risk. Question 3. Scenario-based patient positioning and scan acquisition. Dr. Patel is performing a DA scan on a 70-year-old male patient with a history of lumbar spine osteoarthritis. During the scan, he notices increased bone density readings in the lower region compared to previous scans. The patient has no recent fractures or changes in medication. What is the most appropriate next step? A. Accept the results as an improvement in bone density and update the patient's treatment plan accordingly. B. Investigate for possible artifacts or degenerative changes affecting the scan and consider excluding affected vertebrae from the analysis. C. Perform whole-body SA scan to confirm bone density improvement before making any decisions. D. Recommend starting bisphosphonate therapy based on the increased density measurements. Answer. B. Investigate for possible artifacts or degenerative changes affecting the scan and consider excluding affected vertebrae from the analysis. Explanation. Degenerative changes such as osteoarthritis or aortic calcifications can cause artificially elevated BMD readings in the lumbar spine. The IST recommends that when interpreting DSA scans in elderly patients, radiologists and technologists should identify artifacts and degenerative changes that may scare BMD values. Consider excluding affected vertebrae, e.g., below from analysis if they show abnormalities. Use alternative sites such as the femoral neck or total hip for a more accurate assessment. Incorrect answer analysis. A is incorrect because an increase in BMD in an elderly patient with no treatment changes is suspicious for scan artifacts rather than true bone density improvement. C is incorrect because whole-body ESA scans are not typically used for diagnosing osteoporosis, are less reliable than site-specific scans. Spine Hay. D is incorrect because initiating bisphosphonates based on potentially inaccurate DRK readings may lead to unnecessary treatment. Relevant guidelines. The IST official position on DSA interpretation recommends verifying scan accuracy, identifying artifacts, and considering clinical history before making treatment decisions. Question 4. Topic: DSA scan interpretation and clinical application. The 63-year-old postmenopausal woman undergoes a DA scan to assess her bone mineral density, BMD. Her T-score at the lumbar spine is negative 2.6, at the total hip is negative 2.3, and at the femoral neck is negative 2.5. She has history of vertebral compression fracture that occurred after minimal trauma. Her physician considering whether she qualifies for an osteoporosis diagnosis and what treatment plan would be appropriate. Based on the World Health Organization WHO criteria, which of the following is the best classification of her bone health status? A. Osteopenia. B. Osteoporosis. C. Severe, established osteoporosis. D. Normal bone density. Answer C. Severe, established osteoporosis. Explanation: that WHO defines osteoporosis as a T-score equals negative 2.5 at any major site, lumbar spine, hip, or femoral neck. Osteopenia is defined as T-score between negative 1.0 and negative 2.4. This patient's T-score at the lumbar spine, 2.6, and femoral neck, 2.5, meets the osteoporosis threshold. Severe established osteoporosis is diagnosed when osteoporosis is present along with fragility fracture, which she has experienced, vertebral compression fracture. Since her condition includes both lobing and fracture, she is classified as having severe established osteoporosis, warranting pharmacologic treatment and fall prevention strategies. Relevant guidelines. WHO criteria for osteoporosis diagnosis. National Osteoporosis Foundation (NOF) treatment guidelines recommend pharmacologic treatment for postmenopausal women with T-score equals negative 2.5 or those with history of fragility fractures. Question 5. Topic: Quality control and assurance in densitometry. A densitometry technologist is responsible for ensuring accurate and consistent DRK scan results in a clinical setting. Over the past 6 months, the facility has switched DSA machines from manufacturer A to manufacturer B. The technologist notices a systematic difference in T-scores, with readings on the new machine being consistently higher by 0.4 to 0.6 standard deviations. What is the best course of action to ensure the accuracy of serial BMD measurements in patients who have scans on both machines? A. Retake all previous patient scans on the new machine to ensure consistency. B. Apply a cross-calibration equation to adjust for machine differences. C. Disregard previous BMD results and begin tracking patient BMD from the new machine only. D. Use an absolute BMD value, GCM, rather than T-scores when comparing results from different machines. Answer B. Apply a cross-calibration equation to adjust for machine differences. Explanation: when transitioning between different DSA machines or manufacturers, systematic differences can occur due to differences in calibration and measurement algorithms. Cross-calibration involves scanning the same phantom or reference patients on both machines and deriving an adjustment equation to correct for measurement discrepancies. Option D. Using absolute BMD values is a good practice, but it does not completely resolve systematic biases between different machines. Rescanning all previous patients, option A, is impractical and may expose patients to unnecessary radiation. Ignoring prior BMD values, option C, is inappropriate as historical data is critical for monitoring changes in bone health. Relevant guidelines. IST position statement: cross-calibration quality control and assurance in bone densitometry. Question 6. Scenario-based. Topic: osteoporosis and bone diseases. Dr. Ramirez, a primary care physician, is evaluating Mr. Thompson, a 70-year-old man with a history of chronic kidney disease. C. A recent essay scan shows a t-score of -2.7 at the femoral neck and z-score of -1.8 at the lumbar spine. His serum calcium and phosphate levels are within normal limits, but he elevated parathyroid hormone (PH) level. Given these findings, what is the most likely underlying cause of his low bone mass? A. Primary osteoporosis. B. Osteomalacia. C. Secondary osteoporosis due to renal osteodystrophy. D. Paget's disease. Answer: C. Secondary osteoporosis due to renal osteodystrophy. Explanation: chronic kidney disease (CKD) can lead to renal osteodystrophy, a condition where kidney dysfunction disrupts calcium, phosphate, and vitamin D metabolism, leading to secondary hyperparathyroidism and bone loss. Primary osteoporosis, option A, is less likely, as the presence of CKD and high pH suggests an alternative mechanism. Osteomalacia, option B, is characterized by bone softening due to defective mineralization, often seen with low vitamin D and hypocalcemia, which are not present here. Paget's disease, option D, is disorder of abnormal bone remodeling and typically presents with localized bone thickening, pain, and elevated alkaline phosphatase, which are absent in this case. Relevant guidelines: National Kidney Foundation in Kiev, Guidelines on Bone in CAD. IST guidelines on bone densitometry in patients with chronic kidney disease. Question 7. Topic: Patient positioning and scan acquisition during a DA scan. Mrs. Anderson, a postmenopausal woman, is positioned incorrectly with her legs in an excessively flexed position during a lumbar spine scan. How might this positioning error affect the BMD results? A. It will forcefully increase the measured BMD. B. It will forcefully decrease the measured BMD. C. It will not impact the BMD measurement. D. It will lead to an error message and prevent the scan from completing. Answer: A. It will falsely increase the measured BMD. Explanation: excessive flexion of the legs during a lumbar spine DSA scan flattens the lumbar spine, artificially increasing vertebral body overlap and reducing the space between vertebrae. This can cause artificially higher BMD values, potentially masking osteoporosis and leading to misdiagnosis. Option B, decreasing BMD, is incorrect because excessive leg flexion reduces the apparent vertebral height, leading to overestimated BMD rather than underestimation. Option C, no impact, is incorrect because positioning directly affects measurement accuracy. Option D, error message, is incorrect because DSA software does not automatically detect poor positioning unless obvious artifacts are present. Relevant guidelines: IST official position on proper DSA positioning guidelines for standardized patient positioning in bone densitometry. Question 8. Topic: T-scores versus Z-scores in clinical practice. Dr. Patel is interpreting a DA scan for a 45-year-old premenopausal woman with a history of early menopause due to surgical oophorectomy. Her scan results show lumbar spine T-score, -2.4, total hip T-score, -1.8, femoral neck Z-score, -2.1. Which of the following is the most appropriate interpretation of these results? A. The patient has osteoporosis based on her T-score. B. The patient has osteopenia because her Z-score is below -2.0. C. The Z-score suggests secondary bone loss and requires further investigation. D. The T-score should be used for diagnosis in premenopausal women, so she does not meet osteoporosis criteria. Answer: C. The Z-score suggests secondary bone loss and requires further investigation. Explanation: T-scores are not used to diagnose osteoporosis in premenopausal women. Instead, Z-scores compared to age-matched controls are used. Z-scores 50 years old. Option B, osteopenia by Z-score, is incorrect since osteopenia is defined by T-scores, not Z-scores. Option D, ignoring Z-score, is incorrect because premenopausal women with low Z-scores should be evaluated for secondary causes. Relevant guidelines: IST official position on Z-scores in premenopausal women, National Osteoporosis Foundation (NOF). Recommendations. Question 9. Topic: Takesai's scan limitations in patients with spinal degeneration. A 72-year-old man with chronic low back pain and spinal osteoarthritis undergoes a DA scan. The scan shows a T-score of -1.1 at the femoral neck and T-score of -0.5 at the lumbar spine, despite known clinical signs of osteoporosis. Which of the following best explains why his lumbar spine BM may be artificially elevated? A. Vertebral fractures can increase bone density measurements. B. Osteoarthritis and aortic calcifications can falsely elevate BMD in the lumbar spine. C. Incorrect patient positioning can lead to overestimation of BMD. D. The femoral neck is poor site for detecting osteoporosis in older adults. Answer B. Osteoarthritis and aortic calcifications can falsely elevate BMD in the lumbar spine. Explanation: degenerative changes, osteophytes, sclerotic changes, and calcifications in the spine can cause artificially high BMD readings. Vertebral fractures, option A, usually decrease BMD, not increase it. Patient positioning, option C, can affect scan accuracy, but it does not specifically cause an artificially BMD in degenerative disease. The femoral neck, option D, remains a critical site for detecting osteoporosis, especially in the elderly. Relevant guidelines: its position on artifacts and DSA imitations. WHO recommendations on fracture risk in elderly patients. Question 10, scenario-based. Topic: secondary osteoporosis and glucocorticoid use. Mrs. Johnson, a 68-year-old woman with rheumatoid arthritis, has been taking prednisone 10 mg day for the past 3 years. A recent DSA scan shows lumbar spine T-score negative 2.8, femoral neck T-score negative 2.5, total hip T-score negative 2.3. Which of the following is the best next step? A. No intervention is needed as her T-scores indicate osteopenia. B. Initiate bisphosphonate therapy and monitor her bone density. C. Perform FRAX assessment and only treat if the fracture risk is high. D. Repeat DSA in 1 year and reassess her risk factors. Answer B. Initiate bisphosphonate therapy and monitor her bone density. Explanation: glucocorticoid-induced osteoporosis (GIP) is a major concern in patients on long-term steroid therapy. A T-equals executive 2.5 warrants treatment regardless of FRAX results. Bisphosphonates e.g. alendronate, ristronate are first-line therapy for GIP. Option A, no treatment, is incorrect because she already meets osteoporosis criteria. Option C, using FRAX, is unnecessary because FRAX is most useful for osteopenia cases, not established osteoporosis. Option D, waiting 1 year, is inappropriate for high-risk patients. Relevant guidelines: American College of Rheumatology, ACA, Guidelines on GIP, ISKA-NOF recommendations. Question 11, topic: indications for decade scanning. A 45-year-old man with no history of fractures presents for a routine checkup. He is in good health but has a family history of osteoporosis. His physician is uncertain whether to order a DA scan. Which of the following is the strongest indication for a DA scan in this patient? A. Age 40. B. Family history of osteoporosis. C. History of prolonged glucocorticoid use. D. No history of fractures. So DSA is not needed. Answer C. History of prolonged glucocorticoid use. Explanation: DSA scans are recommended for men age 50 and postmenopausal women. However, younger adults should undergo DSA if they have risk factors such as chronic steroid use, fractures, or metabolic bone disorders. Family history alone, option B, is risk factor but not sole reason for DSA. Relevant guidelines: NOF and ISK guidelines are DSA indications. Question 12, topic: treatment decisions based on FRAX scores. A 62-year-old woman has a T-score of negative 1.9 at the femoral neck and no prior fractures. Her FRAX score indicates 10-year major osteoporotic fracture risk of 22% and hip fracture risk of 4.8%. What is the best management option? A. No treatment. Recommend lifestyle changes. B. Start bisphosphonate therapy based on FRAX risk. C. Repeat DSA in 2 years. D. Order spine X-ray before making treatment decisions. Answer B. Start bisphosphonate therapy based on FRAX risk. Explanation: FRAX thresholds for treatment: 20% major osteoporotic fracture risk, 3% hip fracture risk. Since both thresholds are exceeded, pharmacologic treatment is warranted. Relevant guidelines: WHO and NUG guidelines on FRAX. Question 13, topic: BMD measurement in special populations. A 32-year-old woman with Turner syndrome is referred for a bone density evaluation due to her short stature and history of estrogen deficiency. Her DSA scan results are lumbar spine Z-score negative 2.3, total hip Z-score negative 1.8. Which of the following is the most appropriate next step? A. Diagnose osteoporosis based on the Z-score. B. Recommend repeat DSA in 5 years as she is premenopausal. C. Evaluate for secondary causes of low BMD and consider estrogen replacement. D. Ignore the DSA results as osteoporosis cannot be diagnosed in premenopausal women. Answer: C. Evaluate for secondary causes of low BMD and consider estrogen replacement. Explanation: Z-scores, not T-scores, are used in premenopausal women. Z-equals 2.0 suggests secondary osteoporosis, requiring further evaluation. Turner syndrome is associated with estrogen deficiency, major cause of low BMD. Estrogen therapy is often indicated to improve BMD in these patients. Relevant guidelines: Ist official positions on DSA in premenopausal women. Question 14. Topic: BMD and fracture risk in men. A 67-year-old man presents with chronic corticosteroid use, prednisone 7.5 mg daily for 5 years for COD. DSA scan results: lumbar spine T-score negative 2.7, femoral neck T-score negative 2.1. What is the best next step? A. No treatment unless he sustains fracture. B. Recommend lifestyle changes and vitamin D supplementation only. C. Initiate bisphosphonate therapy due to high fracture risk. D. Reassess BMD in 2 years before making treatment decisions. Answer: C. Initiate bisphosphonate therapy due to high fracture risk. Explanation: glucocorticoid-induced osteoporosis (GIP) increases fracture risk significantly. T-score 50 years warrants treatment. Option A is incorrect because waiting for fracture increases morbidity. Option B is insufficient as pharmacologic therapy is needed. Option D is incorrect as delaying treatment may lead to fractures. Relevant guidelines: American College of Rheumatology (ACA) Guidelines on GIP. Enough guidelines on osteoporosis in men. Question 15. Scenario-based topic: trabecular bone score TBA. A 55-year-old postmenopausal woman with EDM and AR of 32 kilograms undergoes DSA scan. Lumbar spine T-score negative 1.0, femoral neck T-score negative 0.8, trabecular bone score TBS low quality. Which of the following best explains why a fracture risk is still high despite normal BMD? A. Diabetes is not risk factor for fracture. B. TBS reveals poor bone microarchitecture, increasing fragility. C. DKA scans are not useful for fracture risk assessment in diabetes. D. BMI protects against osteoporosis. Answer: B. TBS reveals poor bone microarchitecture, increasing fragility. Explanation: TBS evaluates trabecular bone microarchitecture independent of BMD. Patients with diabetes often have compromised bone quality despite normal BMD. Option A is incorrect because diabetes is a significant risk factor for fractures. Option C is incorrect because DSA plus EBS is useful in diabetes. Option D is incorrect as obesity does not always protect against fractures. Relevant guidelines: Ist position on TBS in diabetes. Question 16. Topic: DSA scan interpretation in young athletes. A 19-year-old female gymnast with a history of amenorrhea for 10 months undergoes a DA scan. Lumbar spine Z-score negative 2.5, femoral neck Z-score negative 2.1. Which of the following is the most likely underlying cause of her OBMD? A. Genetic predisposition to osteoporosis. B. Calcium and vitamin D deficiency. C. Functional hypothalamic amenorrhea. D. High-impact sports weaken bone structure. Answer: C. Functional hypothalamic amenorrhea. Explanation: athletic amenorrhea. Low estrogen causes secondary osteoporosis in young women. Low estrogen leads to decreased bone formation and increased resorption. Option A is incorrect because genetic osteoporosis is rare at this age. Option B is possible but not the most likely explanation. Option D is incorrect because weight-bearing exercise usually strengthens bones. Irrelevant guidelines: female athlete triad and bone health guidelines. Question 17. Topic: DA in CAD patients. A 70-year-old woman with chronic kidney disease CAD stage 4 has a DA scan showing lumbar spine T-score negative 2.8, femoral neck T-score negative 2.6. Which of the following best explains that DSA alone is not enough for diagnosing osteoporosis in CKD? A. ESA overestimates CMD CAD patients. B. Bone quality, not just EMD, determines fracture risk in CKD. E. DSA is not recommended for CKD patients. D. DKK is unreliable in postmenopausal women. Answer: B. Bone quality, not just BND, determines fracture risk in C or D. Explanation: CKD associated bone mineral disorders affect bone quality, not just density. Additional tests, e.g., bone turnover markers, biopsy, may be needed. Option A is incorrect because DSA may over or underestimate BMD. Option C is incorrect since DSA is still useful but requires caution. Option D is incorrect as DSA is reliable in postmenopausal women. Relevant guidelines: KDIGO guidelines on bone health in E. Question 18. Topic: bisphosphonate therapy duration. A 72-year-old woman has been on alendronate for 6 years with stale BMD and no fractures. What is the best next step? A. Continue alendronate indefinitely. B. Discontinue alendronate and monitor BMD. C. Switch to denosumab. D. Increase the alendronate dosage. Answer: B. Discontinue alendronate and monitor BMD. Explanation: a bisphosphonate holiday is recommended after 5 years in low-risk patients. Option A is incorrect since prolonged bisphosphonate use increases atypical fracture risk. Option C is unnecessary unless fracture risk increases. Option D is incorrect as increasing dosage is not standard. Irrelevant guidelines: asthma guidelines on bisphosphonate holiday. Question 19. Topic: DSA in bariatric surgery patients. A 45-year-old woman underwent Roux-en-Y gastric bypass surgery 3 years ago. She has no history of fractures but reports chronic vitamin D deficiency. Her DSA scan shows lumbar spine T-score, negative 2.6. Femoral neck T-score, negative 2.4. What is the next best step? A. Start calcium and vitamin D supplementation and repeat DSA in 5 years. B. Prescribe bisphosphonates immediately. C. Assess bone turnover markers and consider anabolic therapy if needed. D. Disregard ESA results as it is not useful post-bariatric surgery. Answer: C. Assess bone turnover markers and consider anabolic therapy if needed. Explanation: bariatric surgery increases osteoporosis risk due to malabsorption of calcium and vitamin D. Bone turnover markers help assess if there is active bone loss. Bisphosphonates should be used cautiously due to absorption issues. Option A is incorrect since long-term monitoring is needed more frequently. Relevant guidelines: ISCT Endocrine Society guidelines on BMD monitoring in bariatric surgery patients. Question 20. Scenario-based. Topic: osteoporosis and fracture risk assessment. A 68-year-old postmenopausal woman presents with a distal radius fracture after falling from standing height. Her DSA scan shows lumbar spine T-score, negative 1.8. Femoral neck T-score, negative 1.6. What is the most appropriate next step? A. Do nothing since her T-scores do not meet osteoporosis criteria. B. Calculate FRAX score and initiate therapy if fracture risk is high. C. Repeat DSA in 2 years before considering treatment. D. Order bone biopsy to confirm osteoporosis. Answer: B. Calculate FRAX score and initiate therapy if fracture risk is high. Explanation: a fragility fracture indicates high fracture risk regardless of T-score. FRAX helps determine if pharmacologic treatment is needed. Option A is incorrect because fractures in older adults indicate underlying osteoporosis. Option C delays necessary treatment. Option D is unnecessary for diagnosis. Relevant guidelines: NOF and ISCT guidelines on osteoporosis management. Question 21. Topic: pediatric essay and interpretation. A 14-year-old boy with Crohn's disease is undergoing chronic steroid therapy. His DSA scan results: lumbar spine Z-score, negative 2.2. Total body Z-score, negative 2.1. How should his results be interpreted? A. Osteoporosis should be diagnosed based on Z-scores. B. Z-scores indicate low bone mass, but osteoporosis is not diagnosed. C. T-scores should be used instead of Z-scores. D. His results are normal for grown adolescent. Answer: B. Z-scores indicate low bone mass, but osteoporosis is not diagnosed. Explanation: osteoporosis in children is diagnosed based on fractures, not just DSA Z-scores. Z equals negative 2.0 suggests low bone mass and requires further evaluation. T-scores are not used in children. Relevant guidelines: ISCT Pediatric DSA Interpretation Guidelines. Question 22. Topic: trabecular bone score, TBS, and diabetes. A 60-year-old man with type 2 diabetes, TDM, has a DA scan, lumbar spine T-score, negative 0.9, femoral neck T-score, negative 1.0, trabecular bone score, TBS, Low. Why does he still have an increased fracture risk? A. Diabetes does not impact bone health. B. TBS reflects bone quality, which is often impaired in diabetes. C. Derkay does not accurately assess BMD in diabetes. D. He has normal BMD, so fracture risk is not increased. Answer B. TBS reflects bone quality, which is often impaired in diabetes. Explanation: patients with diabetes have compromised bone microarchitecture even with normal BMD. The BS provides additional fracture risk assessment. DSA alone underestimates fracture risk in diabetes. Relevant guidelines: ISTN ADA guidelines on bone health in diabetes. Question 23, topic: bone markers in osteoporosis management. A 65-year-old woman on teriparatide for osteoporosis undergoes lab testing. Which of the following changes is expected? A. Decreased serum PNP. B. Increased bone resorption markers. C. Increased PNP and bone formation markers. D. No changes in bone turnover markers. Answer C. Increased PNP and bone formation markers. Explanation: teriparatide stimulates osteoblast activity, increasing bone formation markers, PNP, a key marker of bone anabolism. Relevant guidelines: ISTN Endocrine Society guidelines on bone turnover markers. Question 24, topic: osteoporosis treatment failure. A 74-year-old woman on alendronate for 5 years presents with a new vertebral fracture. What is the next best step? A. Continue alendronate as fractures can occur despite treatment. B. Switch to a parathyroid hormone analog like teriparatide. C. Stop all treatment and reassess in 2 years. D. Repeat ESA. Scan before making any changes. Answer B. Switch to a parathyroid hormone analog like teriparatide. Explanation: a new fracture despite bisphosphonates indicates treatment failure. Anabolic agents like teriparatide are preferred in high-risk patients. Relevant guidelines: ASMA and NOF guidelines on osteoporosis treatment failure. Question 25, topic: frax adjustments. A 64-year-old woman has a hip T-score of -1.7 and frax 10-year hip fracture risk of 2%. However, she has had 2 previous vertebral fractures. How should her frax result be adjusted? A. Use frax as is, since fractures don't impact the score. B. Increase frax risk estimation manually. C. Ignore frax since she already meets osteoporosis criteria. D. Repeat frax using secondary osteoporosis input. Answer B. Increase frax risk estimation manually. Explanation: frax underestimates risk in patients with multiple fractures. Adjusting manually accounts for additional risk factors. Relevant guidelines: ISTN WHO guidelines on frax interpretation. Question 26, topic: DSA accuracy and artifacts. A 72-year-old woman with severe osteoarthritis and multiple lumbar vertebral osteophytes undergoes a DA scan. Her lumbar spine T-score is 1.2, but her femoral neck T-score is -2.5. What is the most likely explanation for this discrepancy? A. The femoral neck measurement is inaccurate due to hip osteoarthritis. B. The lumbar spine DSA is falsely elevated due to degenerative changes. C. The patient has true normal bone density in the spine, but osteoporosis in the hip. D. The femoral neck measurement should be ignored in favor of the spine. Answer B. The lumbar spine DSA is falsely elevated due to degenerative changes. Explanation: degenerative changes, osteophytes, aortic calcifications, vertebral fractures, falsely elevate BMD in the lumbar spine. In such cases, hip EMD or 4 BMD should be prioritized for fracture risk assessment. Option C is incorrect since osteoarthritis often skews lumbar spine readings. Relevant guidelines: IST recommendations on DSA interpretation with artifacts. Question 27, scenario-based. Topic: secondary osteoporosis evaluation. A 55-year-old man with no history of fractures is referred for a DA scan due to low testosterone levels. His DSA results: lumbar spine T-score, -2.7. Femoral neck T-score, -2.3. Which of the following should be evaluated next? A. No further workup needed. Initiate bisphosphonates. B. Serum calcium, 25-hydroxyvitamin E, pH and testosterone levels. C. Repeat the assay in 1 year before considering treatment. D. Only treat if the patient has history of fractures. Answer B. Serum calcium, 25-hydroxyvitamin D, pH and testosterone levels. Explanation: Low testosterone is a known cause of secondary osteoporosis. Other secondary causes, such as vitamin D deficiency or hyperparathyroidism, should be excluded. Treatment should be based on underlying etiology. Relevant guidelines: ISKCON Endocrine Society Guidelines on Secondary Osteoporosis. Question 28. Topic: Atypical femoral fractures and long-term bisphosphonate use. A 66-year-old woman has been on alendronate for 10 years for osteoporosis. She reports thigh pain and an X-ray reveals a transverse femoral shaft fracture with cortical thickening. What is the most appropriate next step? A. Continue alendronate as the patient is at high fracture risk. B. Discontinue alendronate and switch to A. Inog-like teriparatide. C. Increase alendronate dose to promote healing. D. Ignore the X-ray findings unless a complete fracture occurs. Answer: B. Discontinue alendronate and switch to Inog-like teriparatide. Explanation: Atypical femoral fractures (AFs) are associated with prolonged bisphosphonate use. Stopping bisphosphonates and starting anabolic therapy can promote healing. Option A is incorrect, as continued bisphosphonate use increases AF risk. Relevant guidelines: Asthma and IST Guidelines on Atypical Femoral Fractures. Question 29. Topic: DSA in chronic kidney disease. A 69-year-old man with stage 4 chronic kidney disease (CAD) undergoes a DA scan with the following results: lumbar spine T-score, negative 2.4, femoral neck T-score, negative 2.1, serum calcium, 8.5 VDL, low normal pH, 205 pgml, elevated. What is the most appropriate interpretation? A. DSA cannot be used in a CAD, so the results are unreliable. B. A BMD suggests osteoporosis, but secondary hyperparathyroidism must be addressed first. C. Initiate bisphosphonates immediately to prevent fractures. D. Bone biopsy is required before any treatment decisions. Answer: B. Low BMD suggests osteoporosis, but secondary hyperparathyroidism must be addressed first. Explanation: Patients with CAD often have renal osteodystrophy, requiring differentiation from primary osteoporosis. Elevated pH suggests secondary hyperparathyroidism, which affects bone metabolism. Treatment should target both osteoporosis and EED, chronic kidney disease, mineral and bone disorder. Relevant guidelines: K. Digonis recommendations on EAE. Question 30. Topic: Bone health in transgender patients. A 32-year-old transgender woman, assigned male at birth, has been on estradiol therapy for 5 years but has suboptimal testosterone suppression. A DA scan shows lumbar spine T-score, negative 2.2, femoral neck T-score, negative 1.8. What is the best approach to optimize bone health? A. Start bisphosphonates immediately. B. Ensure adequate estradiol therapy and suppress endogenous testosterone. C. Stop all hormone therapy and monitor DSA in 2 years. D. No intervention is needed since the patient is young. Answer: B. Ensure adequate estradiol therapy and suppress endogenous testosterone. Explanation: Estradiol is essential for maintaining bone health in transgender women. Inadequate testosterone suppression may impair bone preservation. Bisphosphonates are not the first-line treatment unless fractures occur. Relevant guidelines: Endocrine Society and IST Guidelines on Bone Health in Transgender Individuals.